Hi, I'm Geoff Kane with 2 quick points before you get into this training video on motivational interviewing. The first is that motivational interviewing was designed to help individuals resolve ambivalence in the direction of healthy behavior change. And that's what the methods that you'll hear about are all about. However, the spirit of motivational interviewing, the empathic, non-judgmental position of the interviewer, is something that we would all do well to have everywhere in all our dealings with other people. Second, the terminology is evolving, changing, and the word resistance is not used so much in MI anymore, even though you'll hear me use it in this training. What used to be called resistance is now being considered under the headings of sustained talk on the part of the person being interviewed and discord, perhaps between the interviewer and the interviewee. Thanks.
Okay, welcome everyone. This is an interactive workshop introduction to motivational interviewing. The sequence will be kind of lecture discussion, PowerPoint slides to set up the topic. Then we want to illustrate motivational interviewing in action, and I'll conduct a demo interview that you can look at. And there are certain things that in research studies and training get scored or rated in the course of an interview. And you'll have an opportunity to volunteer and do that with me, or everyone can have a score sheet and do that with me. And then we want to break up into groups of 3 where each of you will have an opportunity to interview another one of you with an observer or a rater. And when we get to that exercise, we call it real play, because you're invited to think of something that you're ambivalent about, really mostly interested in changing but haven't been able to change. And that sets you up to talk in a framework that might help move that process along, which is the whole point. Just how many people have a familiarity with MI or motivational interviewing? Had training in it? Done it? I want to put it in a bit of context. This is the annual report of Youth Services in Brattleboro. Slogan is transforming lives, inspiring futures. And in the introduction, the executive director finishes with this paragraph. So whether it is a youth services case manager with a homeless young adult, a court diversion panel volunteer with someone taking responsibility for the harm they caused, or a mentor encouraging a young person to speak up in our youth-led screen printing business, Youth Services puts relationships at the center of all we do. It is how we intervene. Relationships are how they intervene. The first training I had in addiction medicine, and I'm a medical doctor have been involved in addiction medicine for 45 or so years, and motivational interviewing began in addiction treatment. It has subsequently spread to primary care and mental health services, corrections, adolescent helping. So it's an evidence-based tool that we'll be talking about and learning more about. But in 1974, I had my first training at the Smithers Center in New York City, and part of that was at Chit Chat Farm in Pennsylvania, now the Karen Center, or Karen Foundation. And Karen at that time had a brochure kind of with thumbnail sketches and photographs of their clinical staff. But at the top it said, the treatment of addiction, it might have said alcoholism in those years, but the treatment of addiction is people, and meet ours. And that phrase, the treatment of addiction is people, has stayed with me over these decades and has been borne out over and over and over again in my own experience. I think of working in inpatient units where people are struggling, and what would anchor them there would be a connection they would make with a staff member or perhaps another patient or a group of them. Relationships carry a lot of the weight of what we want to do when we're helping people. I've heard the phrase repeated many times by clinicians, but recently heard it from the parents of an adult male affected by schizophrenia who's had years of treatment, functioning, and on and off a whole variety of medications, but the father of that young man, in summing things up, he said, it's all about the relationships. Maya Angelou will tell us that it's all about the relationships, and especially the feeling aspects of relationships. I'll look at Jim. Some of us in the room have been around mental health for quite a while and can reflect on how the emphasis in treatment and looking to help people has largely been on cognition and how people think and trying to help them think in a more adaptive way. There's call it a paradigm shift in mental health care toward the importance of feelings, affect. And if we think about development, it's about affect. Mother and one-year-old son on his first birthday, and these two people they're not just color coordinated, they're neurobiologically coordinated. The developing brain for 2-3 years doesn't do much with cognition. Try to teach a one-year-old math. It's all about affect. And developmental neurobiologists like Alan Shore would say, no, this is all right brain to right brain. And it's crucial to the physical development of the child's brain and also to the functional development of the child's brain. And it doesn't stop with childhood. As adults, now, I'm fond of saying there's more to who we are and why we do the things we do than what meets our own mind, which is an acknowledgement of the unconscious. Psychologist Robert Ornstein says, we're worse off than Freud thought. That unconscious affect comes out not just in slips of the tongue in our dreams, but it comes out all the time in our behavior. Who here has heard of Bonnie Raitt? Young group. Who's heard this Bonnie Raitt song, Let's Give Them Something to Talk About? To me, that's a sort of an adult story from the singer's point of view, getting into a romance, not even noticing it. We stand a little too close, we laugh a little too loud, but the singer doesn't even appreciate the romance is happening till friends point it out, and then say, okay, so let's go for it. Let's give them something to talk about. Let's really have a romance. But it began under wraps. Patients are generally more spontaneous and honest about answering this question than staff, but here we go. Has anybody here ever flirted with someone before you realized that you were sexually attracted to them or attracted to them? Okay, heads are nodding. In addiction treatment generally, there hasn't been enough attention paid to the process that we're talking about. Knowledge-focused education and insight-oriented persuasion have been spectacularly unsuccessful at helping people deal with substance abuse and addiction. On the other hand, relationship matters. There's something therapeutic about certain relationships. For years in addiction treatment, I did group work with patients, and I'd heard the term psychoeducational groups, so I said, well, I do psychoeducational groups. And then I learned that the research said that doesn't work. I rebranded what I was doing to what I consider a more accurate description. I was leading themed process groups. So there might have been a topic, but there was a lot of interaction and a lot of acknowledgement of where the people in the group were coming from. It wasn't a didactic presentation, because that's what's been shown not to work. Motivation is what underlies behavior and can lead to change. And change, or motivation rather, is not a trait. I mean, you could measure how tall I am, and that would be sort of a trait. It's kind of a fixed characteristic. If we thought about my bowling ability, that would be a state. I haven't done that for years, so I don't expect I would be pretty good. But that could change with practice and coaching and sort of repetition. How well I bowl can get better or worse as I go along. And that can be a function of relationship. And that's where we come in. We have all kinds of fancy things we do, especially with medications these days, to try to affect a client or a patient's brain. It's important to remember that we, as clinicians, in our relationship with patients, we are a brain treatment and can influence how they go. And that's consistent with that shift in the science, going more from cognition to affect. But what motivational interviewing does, it lends sort of some specific things that we can do that will improve our effectiveness. And it's in the flow with humanistic psychology. Things have been getting more scientific. Attachment theory, developmental neurobiology, interpersonal neurobiology, things are getting more scientific, supporting sort of what we're going to be talking about. And MI itself is a evidence-based practice. The nurse at the window of the self-esteem clinic is saying to Ziggy, "Not you again." This is not motivational interviewing. But the nominal clinician could be having an effect on the nominal patient or client. Motivational interviewing has been associated in many people's minds with Prochaska and DeClementi's trans-theoretical model of change, going from pre-contemplation to contemplation to action. And the developers of MI, Miller and Rolnick, have pointed out that this trans-theoretical model and motivational interviewing grew up together, but they're not the same thing. And some people have mistakenly said that MI is based on this, but I think they say they're like kissing cousins that never married. And one of the misconceptions about motivational interviewing is that it involves placing people in this cycle. And I like these cycles when they're drawn with an entry point and an exit point, because it doesn't have to spin forever. People think that MI is placing someone in a stage of change and then doing something about that. Now, it can be helpful to conceive of people like this in this wheel. If I'm talking to somebody who smokes cigarettes and they don't think it's a problem, I might want to get them uncomfortable with that, with sort of information if they're willing to receive the information. If they're thinking about it, I want to reinforce that. And if they're getting ready to take action, all the conversation might be about nicotine replacement therapy or what kind of pharmacology to use. Here's a definition from the Miller and Rolnick 2009 paper, 10 Things That Motivational Interviewing Is Not. There are some other definitions that are sort of on the end of the slide handout that you'll get that are taken from the third edition textbook of motivational interviewing by Miller and Rolnick. And they move from the more general to the more technical, but this is ideal for our conversation right now. Motivational interviewing is a collaborative, person-centered form of guiding to elicit and strengthen motivation for change. And if you remember the title slide, the subtitle under motivational interviewing was more of ourselves, I'm sorry, less of ourselves means more for others. And I think it's important to bear in mind as we aspire to and do motivational interviewing to do our best to keep ourselves out of it. To be empathic, we need to kind of be there as an authentic human being. That's good. Yet if the conversation becomes about us and is no longer about the patient or client, then we're getting off track. We may even be derailing what we're trying to accomplish. And motivational interviewing does not refer to everything we do as clinicians. It's a specific approach for helping someone to explore and perhaps even resolve ambivalence. And there are other things we do that don't, we'll talk about open-ended questions. Well, if you're meeting someone for the first time, you might want to fill in a few of the demographic blanks, find out what their home situation is, if they have a place to live, and some specifics about their personal background, family background. And that kind of Q&A has a place in the work that we do, though it's not so much, it doesn't have so much of a place if we're helping through motivational interviewing to help somebody resolve ambivalence. One example, Teresa Moyer's a psychologist, trained in her doctoral work with Bill Miller in Albuquerque and is still on the faculty and collaborates with him. And I consider her a mentor as I've been learning and practicing motivational interviewing. But after she taught in Maine, we had some time for a conversation and skiing came up. She skied, hadn't done it for a while, so continued to ski, and she hadn't made the transition to shaped skis and was curious about that. I said, well, I know something about that. And then I asked her an open-ended question about her skiing. And she said, stop, don't ask me about skiing. I'm at action, tell me about the equipment. It wasn't a time, she wasn't ambivalent. I didn't need to do that stuff. She wanted some information and was asking for it, so that was my role, to provide information. Now, motivational interviewing was designed to favor resolution of ambivalence in a particular direction. Now, if Rory were talking to me and interested in helping me resolve the ambivalence that has been draining my bank account because sort of these cocaine binges kind of fill my weekends, she's got a pretty clear idea of if I'm ambivalent about changing that, which way I ought to go. She's saying, yeah. You betcha. In one demo interview, a clinician offered something that he was ambivalent about. He and his wife had one child. They were ambivalent about having another child. There was no direction there. The interviewer said, well, yeah, I can facilitate discussion of this, but I'm not going to try to steer it one way or the other because there's not a direction. So in general with MI, there's a particular direction that the interview would favor, and ultimately we think the client would favor as well. MI is a relatively brief intervention. 1 or 2 sessions is often what this process takes. It's sort of not the stuff of long-term therapy, although it may come up from time to time and be relevant in long-term therapy. It's consistent with a lot of other things that you might be doing if you're providing long-term therapy. And it explicitly honors autonomy, respecting the patient's independence and point of view, and even supporting that, even if we don't necessarily agree with it. Quote from Tony Mendez by way of a journalist, Sam Walker. Your fate always depends on collaboration. Anybody recognize the name Tony Mendez? An American spy whose probably best known mission was going to a troubled Middle Eastern country to get a bunch of other spies out, and he disguised them as a movie company. The movie Argo portrays that, and Ben Affleck's character is Tony Mendez. Your fate always depends on collaboration. Anybody think of an example of a collaborative conversation where both parties kind of take ownership and work together to achieve a result? What do you think of, Darcy?
Well, the thing that comes to my mind immediately is the state and the retreat administration.
Oh, okay, that's...
I'm not sure we want to go there, but...
Well, let's take it out of politics. Go to theater. Anything come to mind?
Sure, about an actor has an idea and a director is not certain they should go that way.
Okay, and what about sort of stuff that's happening, it's unfolding as it's happening?
In the moment.
Yeah.
Somebody drops something on stage and someone else picks it up.
Oh, well, okay, so in theater, there are sometimes ad libs that have, especially live theater, that have to sort of fit in what's going on. But I'm fishing for improvisation, for improv. What are the rules of improv?
Say yes.
Say yes. That's rule number one. There are 4 rules. If we're doing improv and you say, there was an alligator in the swimming pool, I might say, yes, and it was one huge alligator, it must have been 12 feet long. And you say, yes, and that guy in the clown suit sleeping on the diving board didn't know it was there. And I say, yes, and his long floppy shoe was hanging over the edge of the diving board. It's yes, and it's always statements. I don't want to, if I'm serving to Joaquin, I don't want to ask a question or leave it up in the air. I want to give him something that he can say yes to and move on from. And that fits the process we'll be talking about in motivational interviewing. The rule 4, there are no mistakes, only opportunities. I like a lot, and it helps me to think about sort of clinical situations. I don't know about you guys, but I can be pretty hard on myself if I think I've sort of done something that hasn't helped. And I would say, though, there are no mistakes, only opportunities. I have lost some opportunities because that client-centeredness went away. Something happened that made it about me, and I'll give you some examples of that later on. So there are no mistakes, only opportunities, but as I go about my work, I don't want to lose opportunities. Initially, there was a lot of, in MI training, there was a lot of emphasis on sort of technique and particular things to do and not do. Increasingly, there's been an emphasis on the spirit of MI, the sort of where we're coming from as we get into this. And it's been said MI is like dancing, which is collaborative, not wrestling, which is adversarial. It's like walking with a toddler, where the pace is set by the toddler, the focus of the adult is on the toddler, the destination and safety along the way is on the adult. And that's the directional part of motivational interviewing. Motivational interviewing is, I forget what he says, 80 or 85% based on the work of Carl Rogers, which is sort of empathic, authentic, and the assumption of motivational interviewing is that the client has a drive toward health. And our role is to help the client get ready to hear what they have to say to themselves and then facilitate that they actually say it. So it's not about us, it's about them, and keeping that going is what we're trying to do. I use the walking with a toddler image with a colleague who has 2 little girls under the age of 5. And she said, sure, you're walking along, and then the child sits down and starts screaming, which sort of put a little sand in the engine of my thinking. But in a situation like that, the spirit can still be there of love and acceptance, and even if there's some intervention involved, picking the child up or whatever. Anybody familiar with the name Monty Roberts? Credited as sort of the archetypal horse whisperer. And a lot of MI trainers will show videos of Monty Roberts starting a horse, using horse language, nonverbal communication, equus he calls it, to not break, not wrestle with a horse, but gently guide them into a role with humans. And just Google Monty Roberts videos, and I would encourage you all to do that and watch 1 or 2 of them, because it's a very clinical thing. Bill Miller of Motivational Interviewing has collaborated with Monty Roberts. Apparently the way that started was Bill's wife was watching TV and then came and said, Bill, come look at this. This guy's doing with horses what you do with people. And subsequently the two men have collaborated on stuff. Motivational interviewing is done for and with another person. Non-judgment. And Anthony Martinetti describes himself as a spiritual therapist or clinician. But the impact of our communication on another person depends not so much on what we say as how we say it, and not so much on how we say it as who we are at that moment. If we're being judgmental, it may not help the person that we want to help. In addiction treatment, people who come into inpatient programs or other programs for help are often simmering with self-loathing and self-judgment. One snarky remark from a staff member can pop the cork on that so it boils over in the direction of that staff member and perhaps the whole unit. Determinants of client change. These aren't things that predestine what's going to happen. These are things people look at after the fact to see what influenced good outcomes. And in meta-analyses, things that have to do with the client, him or herself. Somebody with home, a job, intact family, social supports, has a better prognosis entering addiction treatment than somebody who doesn't have any of that. And that's just sort of a prognostic factor that people start out with. In some of the older literature on alcohol addiction, they would talk about social competence, sort of those educational attainment and social supports and some resources. However, the outcomes of a treatment episode are more greatly influenced by this combination of relationship and hope and expectancy, which can flow out of respectful relationships, than the conceptual model of whoever's providing the treatment. And I think providers often get full of themselves with their theory and how it's supposed to be done, or how they did it, or what the particular program they're involved with ought to do, whereas it's really the connection, the relationship, that makes the bigger difference. some of the research base of motivational interviewing goes back. This is a 1970 book, Frontiers of Alcoholism. And Morris Chaffetz is one of the authors, editors. But Chaffetz in, I think, Mass General did some research back pre-1970. And MI grew up in the 80s with the trans-theoretical model of change. But this is cited as some of the research that supports motivational interviewing. Doctors in the emergency room interacting with patients who are there because of something to do with alcohol, or alcohol is maybe incidental to why they're there. But part of the outcome was to refer them to an outpatient clinic for follow-up for the addiction to alcohol. This was pre-video. They had audio tapes of the interaction. They garbled the content and then just listened to the tone of voice of the doctor. And a couple ways they characterized the tone of voice. Someone was angry, perhaps scolding. What do you suppose their follow-up rate was? Nothing. Zero. Whereas doctors whose tone of voice was more one of worry and concern had some of those individuals follow up. So that just another piece of evidence for the importance of relationship. Expectations influence outcomes. I never tire of telling the story of the teacher who was maybe 5th or 6th graders. She got her class list and said, wow, these kids are all in the superior to gifted range. And she had a wonderful year. They did their work. They did well on her tests. They did well on the standardized tests. It was only at the end of the year that she learned that the numbers on her class lists weren't IQ scores. They were her students' locker numbers. But she had the expectation that they were gifted, and they behaved that way. In addiction treatment units, I'm usually pretty low-key, but when somebody says, oh, they're going to go out and drink, I will stop and interrupt and say, wait a minute. That, in some indirect way, maybe spiritual way, can influence the outcome of what happens to that patient. So it's important that we not even embrace that thought or express that thought, and it's better if we don't even have that thought. Kind of generic counseling tips, be empathic, non-confrontational, empathize, offer choices, have confidence. These are pretty generic, but they are also embedded in motivational interviewing. Another round of the spirit of motivational interviewing. Profound respect for the other person. Sort of non-judgment to the max. We don't have to necessarily agree or approve with what the person is saying, but their worth is above question. Accurate empathy, support their autonomy, affirm what's going on with them. Monty Roberts is stroking the horse's nose and directing attention at the horse, and it's sort of a conditioning process. Well, we can smile and we can appreciate the people that we're with and reinforce the process that we're trying to facilitate. Sort of reinforcing their strengths and values to the point where those strengths and values may help lead them into a change that benefits them. Quote from John Hickenlooper, "The only way you persuade someone is to listen harder." I really like this quote, but I have to bend it to make it work with MI, because motivational interviewing is not about persuading someone. It's about listening hard enough so that the person says enough to persuade themselves. What's going on here? They're capsizing the canoe. And I think they've reached a point of no return. Once the definition of capsize is it gets to 90 degrees, but the way they're positioned, I think they've passed the point of no return. If we had a sequence earlier than that, what might someone in the canoe have done to avoid the capsize?
Lean hard to the right.
Lean hard in this orientation. Yeah, go the other way and offset things. Right the canoe. Motivational interviewing talks about the righting reflex. Now, in our sort of selfless, we want to help you, everyone, selves, we can have a natural desire to set things right when someone's on a wrong path. When somebody says something that seems like, Joaquin, you want to go skydiving? Are you sure? Man, is your insurance paid up? If it might not fit with our sense of what we want that person to be doing, and we tend to jump on it, but that can be an overuse of a directing style, stifle the kind of relationship and expression that we want from the patient, and can involve arguing or lecturing. I've wanted to help people so much, I can't count the number of sort of lectures I've given about health and lifestyle and exercise and probably a lot of that was ineffective. I hope it wasn't counterproductive. And there may be a way of doing things that don't fit sort of the pure idea of how someone does motivational interviewing if that non-judgmental spirit is there and caring is there. Sometimes we might call someone out on a behavior and they get it and they're grateful for it. But it's important to be careful. I was so set on myself being helpful that for a while, when I heard about the righting reflex, I thought it was the patient doing the wrong thing, not me doing the wrong thing. In motivational interviewing, it's the person, the client, who does most of the talking. And I like what Bill Miller says, we don't want to steal the best lines because it's when they say it, it has the most impact. I was talking to a young man who was in the hospital for addiction treatment, a problem with opioids. He reported issues with pain. He was wearing a cervical collar some of the time, but it was on so loose, it was part of his conversation, not part of his skeletal support. And he was talking about how going to 12-step meetings in the community wasn't helpful. And I simply made a reflective statement. 12-step meetings aren't useful for you. And he said, no, they haven't been. And they said, but as you say, if I'm in those meetings, I'm not hanging out with people who would be unhealthy for me, and I might get some support for making some changes. I hadn't said that at all. He said it, and that he said it made it all the more powerful and important than if I had said it. So, because I would have been trying to persuade him, but it's only when he saw that it was consistent with his own values and goals and interests that it made more sense to him. So now to finally get more into the process of actually doing this stuff. It's important to engage with whoever the client is. And that means being interested and curious and getting an understanding of their dilemma in their words. And then beyond that, you may be able to focus, evoke some ways that their strengths can play to resolving their dilemma and resolving their ambivalence, and perhaps finally leading to some actually concrete planning. The core skills are open-ended questions, affirming, reflective listening, summarizing, and maybe informing and advising, but not advising without permission. In learning motivational interviewing, the trainers talk about two processes. We can add preferred behaviors like these, but we can also suppress non-behavior, preferred behaviors, like the nurse saying, "Not you again." That we want to eliminate. And the research is showing that it's the elimination of confrontations, advice without permission, directing, threatening, and raising concern without permission. Getting rid of that stuff is more important than cultivating the more technical stuff. Motivational interviewing came into being in the 80s and 90s, and at least at the earlier part of that, addiction treatment was very primitive compared to what most of it is now. It was the days of putting individual patients in the hot seat and breaking through denial. Techniques that we now know are toxic and impair prognosis rather than enhance prognosis. The clinician must not shake what little faith the patient has in himself. With all my focus on there's more to who we are and why we do the things we do than what meets our own mind and feelings, and a lot of addictive behavior is programmed into the brainstem and limbic system and muscle memory so that decisions people behave without making a decision to behave. They'll make a decision not to do certain things and they'll do it anyway. And I liken addiction to how I am, or I expect any of us are. If I hold my breath, kind of as long as I can hold my breath, then I'm going to take a breath and nothing else matters. And with addiction, and that's because of what's going on in my brainstem. It's not a cognitive thing, but addictive behaviors are coming from that primitive part of the nervous system, so that nothing else matters. People will neglect their health, personal safety, family members, loved ones. It's tragic when a parent with addiction loses parental rights to their child, and it happens because they haven't taken the steps that they need to take to sort of get out of harm's way and get help with recovery. But when I hear a patient say, "Well, I've got a lot of willpower," part of me is thinking, yeah, well, but that's not so relevant to addiction recovery if you're in the deep end of the pool of addiction. It may be relevant if you've got more options of that because you're not in over your head yet. But I don't want to jump on that because I don't want to sort of, if that's going to work for them, so be it. I want to let that alone. But it can be tricky. We can get into being the expert or labeling or blaming, and these are non-productive ways to go if the goal is motivational interviewing. And labeling, a guy named Ed Salsitz started revocabularizing addiction medicine several years ago. Let's not talk about clean and dirty urines. Let's talk about urines that are positive for what we expect to be there and negative for what we don't want to see there, or it's unhealthy for the patient to be there. John Kelly in Boston with his group has put out a document called the Addictionary, sort of learning to stop using words like addict and alcoholic and make the language more person-centered. A person with a cocaine use disorder, a person with an alcohol use disorder, an opioid use disorder. I got an interesting insight a few years ago in a community discussion of becoming more person-centered and getting away from stigma, when somebody in the community pointed out that the word enabler is a blaming word. And I've tried very hard not to use that since then, or to put it in some kind of a context. Reflective listening embodies things from Carl Rogers, active listening by Thomas Gordon, who talks about roadblocks. And if we get into a statement or a position where it's sort of one up, well, like we're the expert, or we know what to do, or we know what you should do, that tends to be self-centered, not client-centered, and it impairs the process of helping them make progressive change. And in doing this, briefer is usually better. Sometimes I wish I could take back some of all those lectures or soliloquies or whatever that I've gone through with patients. These are Gordon's roadblocks. He elaborates on those a lot more. If you Google Gordon's roadblocks to communication, you'll get a sort of a development of the items in this list. Listening can actually save time in terms of getting to what the most important or salient things are in helping a patient. And it involves nonverbal and paying attention. Some of you are taking notes, some aren't. I usually take notes. It helps me at a lecture, it helps me be on and stay on and pay attention. If I'm interviewing a patient, my keyboard skills are lousy, so I often take notes, which I worry a little bit may take me away from my presence with the patient, though they also get the message I'm taking it seriously, and it helps my documentation later to do sort of to respect the story that they've shared with me, and I also maybe take more than the average amount of time with the patient, so I think they get the message that I'm present. But it also depends on whether I sort of do summarize what they've said and do make some reflective statements. And as in improv, the reflective statement is a statement. Tone of our voice comes down. It doesn't go up like a question. And so voice inflection matters. And there may be reflections may be simple or complex. We'll say a little bit more about that, and you can think more about that when we get into a demo and your own interviews. And sometimes we make a guess at what the person means, and we sort of continue the paragraph that they started. It's a bit like improv. And sometimes understatements will encourage further exploration. Overstatements sometimes do the opposite. So Andrea says to me, sounds like you were a little upset with your partner the other night. I say, upset? I was ripped. I told you what they did and what they said, the non-apology apology. I was really offended. So I'm elaborating because of her understatement. If it were an overstatement, you really wanted to rip that person's face off. Well, I was pretty upset, but it wasn't that bad. So we can, and this is how the guiding comes in. And so reflections, simple reflection, it just kind of takes something someone said and brings it back. It really scares you to even think about going back to prison again. Complex reflections, there are a lot of angles to that, and we've got a handout on it that we'll pass out before we get into the demo or breakout groups. I'll look at Darcy. You're really in a bind. You told me that new medicine, the alprazolam, the Xanax, is the only thing that's ever helped you this much with anxiety. And on the other hand, you've avoided alcohol all your life because you saw what it did to your father, and now your prescription ran out early and you're learning that Xanax works like alcohol in the brain. Now, in that little thing, which went on a little bit longer than maybe ideal, there was sort of metaphor, you're really in a bind, and it's called a double-sided reflection because it's on the one hand and on the other hand. And there are a lot of different angles to play, and I'll say now when we get into coding, there's reflective, open-ended questions, reflections, summaries, but you only get to code the interviewer statement once. So you put it in one category. And so what I just said I would put in the complex reflection area. We're not set up to do simple versus complex coding, but you can do that if you want. Famous Carl Rogers statement, when I accept myself as I am, then I can change. And this whole process with our non-judgment and facilitation of and evocation of strengths and mistakes, we're helping people in that process of self-acceptance. And I love the bottom one. And we can do that. So fundamental skills, when these are the 4 things that I've tried to memorize when I think of and recite when I think of motivational interviewing. Express empathy, develop develop discrepancy, which is sort of the reality testing of consequences, and also focusing responsibility on the individual. And sometimes that works best with a story, not logic or an abstraction. I think of a teenager who expected to continue smoking marijuana, and when I told the story of the college student who right after I had said in a lecture how bad marijuana messes up immediate recall, the student raised his hand and I said, called on him, he said, I'd like to say a couple things, and I said, sure. And he said, well, I smoke marijuana and I don't think it's that bad, and guy down front says he can't even remember the second thing he was going to say. And the teenager identified with that, and he kept talking about it. So any brain science and stuff I had to say didn't capture his attention the way a story does. And we know that stories light up a whole lot more of the brain than a bullet point. Avoid argumentation. People often say roll with resistance. It's like dancing, not wrestling. And support self-efficacy. Now, I'll save my chuckle, I'll tell it in a second. But OARS is an acronym for open-ended questions, affirming, reflecting, summarizing. And again, if you watch a Monty Roberts interview, or an interaction with a horse, he's sometimes explicit about how he's reinforcing the horse's adaptive behavior, at least adaptive from his point of view. And see if it can make us more attentive to what we do to reinforce healthy movement on the patient's part. Resistance can come from how painful it can be to face the truth and take responsibility for that. And I think it's important for us to understand that, and also kind of leave the timing of that to the individual patient. In addiction treatment, people who have had serious childhood trauma of whatever variety, we often deliberately avoid talking about that and explore more immediate stuff like the ambivalence about abstinence or lifestyle change in the here and now. We might want to let them know that facing the past is incredibly important and powerful, and give them the room to find their own timetable for doing that. Anybody ever increase patient resistance? I haven't done it since yesterday. And I did it yesterday because the patient felt judged. And the patient felt judged because I saw a lesson in what was going on, and I couldn't resist pointing out what could be learned so that the patient could be more adaptive in the future. But it got stuck. I did a lot of backpedaling and empathizing, and I think we got through it. And we wound up with the patient kind of owning their contribution to the sort of break that we had. And a therapist will say, yeah, it's all about sort of rupture and resolve, rupture and resolve. So I mean, there are no mistakes. I hope not in that case. But getting things back together may have left us both in a better place. But that's the snarky remark setting off sort of a patient at the beginning of treatment is an example of feeling judged. And they've got a I'm ready to be judged chip on their shoulder, and we have to be careful not to knock it off. Darcy?
Well, I'm just thinking that for many traumatized patients, certainly they come in with all of these feelings at pretty high levels. And so it's really easy to sort of bump into one of those buttons. So.
And if we're coming from non-judgment, or we can get back there, sometimes I keep my mouth shut with a patient until I can get beyond judgment and find something in their history that I can identify with or come back to. Somebody may have neglected their health in many ways, but they're a musician or something. Avoiding argumentation, resistance is a signal to change strategies. When the patient got upset at what was the topics were, I backpedaled and did more empathizing, a little self-disclosure about how I might have contributed to the person's upset, and we got back on track. Old school addiction treatment, well, you really have to admit that you're an alcoholic. No, I don't care what you call it. There are certain behaviors that are compatible with healthy relationships and greater responsibility, and that we call recovery, but I don't care what you call it. And patients' attitudes are shaped by their own words. It's very important that we, as I said, if they have this drive towards health, we want to prepare them to put their values and dilemma into words, and then say those words with the ability to hear them and take action on them. Resist making the conversation about you. Avoid empathic failure. Reflective statements are often safe defaults. One of my stories, I had a patient in an addiction treatment unit who was there for opioid use disorder, and he had not met criteria for being started on an opioid. I'm not sure whether in those days it was buprenorphine or methadone for detox. And he didn't agree with that. And we were in a one-on-one session, and there was no objective evidence of opioid withdrawal, no sweating, goose flesh, dilated pupils, pallor, what have you. And he was pressing his case. And he said to me, well, you've never been in opioid withdrawal. And I felt attacked, and I wanted to come back, so I said, you don't know that. I was proud of that comment for years. Patients signed out of the hospital either that day or the next day. Lose. Again, there are no mistakes, but there are lost opportunities. And I replay that, and I wish I had made a reflective statement. Something like, you believe if you make me feel guilty or convince me I don't know what I'm doing, I will prescribe a controlled substance for you. I would love to see what he would have done with that, but I lost that opportunity. And sometimes when we make a reflective statement, we're sort of finishing the paragraph and we have like a theory of what's going on that may or may not be right. It's sort of like the guideline in mental health care. Don't be afraid to ask the patient if they're suicidal or not. They're going to sort of respect the question. Well, I would say don't be afraid to make a reflective statement, even if you're kind of stating a theory, because patients tend to correct it right away. And everybody learns from it. There's an Estonian saying, the work will teach you how to do it. And there's something to be said for that. I think if we get into the spirit of motivational interviewing, we can work with it. Yes?
And the previous one, could you give an example of the empathic failure?
I just did.
Does empathic failure not reflect this statement? So what
Well,
would
no,
the difference-
I wasn't empathic in that I wasn't focused on the patient's experience and reflecting that. The patient sort of challenged me and made it about me, and I responded to that. But I'm, I think, long over feeling proud of how I responded to that because it was a lost opportunity. So some specific MI tools. Decisional balance, some people think of MI kind of outdated, but it's about doing pros and cons. Not so much. Pros and cons, I don't really want somebody to tell me what they love about cocaine. But back in that example where the clinician wasn't sure whether he wanted a second child or not, that's value neutral. So then a pros and cons thing may make sense. But if it's where you know the direction and you're confident in the direction of health for this individual, then that's kind of off the menu. Elicit, provide, elicit. We don't want to do stuff without permission most of the time in terms of patient education. Importance and confidence rules frames, let me just briefly say that. So elicit, well, what do you know about smoking and health? Would you like some information from a scientific or a medical point of view? If they give permission, then we can say what we want. Often they have all that information already. And if we facilitate them saying it, it's much better than if we say it. But if we do go through this, then turn it back again and see what the information we provided might have meant for them. Importance and confidence rulers. In motivational interviewing, we're interested in promoting and eliciting change talk. People talk about what their dilemma is and what they might do about it. And we want to reduce the amount of sustained talk, which is them saying sort of why they want to keep doing what they're doing. And the importance and confidence rulers are tools for eliciting change talk. It's not so, how important would you say it is for you to lose weight on a scale from 0 to 10, where 0 is not at all important and 10 is extremely important? Where would you say you are? Patient says 6. Motivation is a state, not a trait. This can move all the time. So we're not going to say, okay, it's sort of, Charlie's a 6. That's what we have. It's part of the conversation. Well, tell me why you picked 6 instead of 3 or 4. Pick a lower number than they said so they can talk about what the reasons that they have for wanting to move in the direction of the change that they're desirous of. And then following the importance ruler, and how confident would you say you are that if you decided to lose weight that you could do it? On a scale from 0 to 10, where 0 is not at all confident and 10 is extremely confident, where would you say you are? And this is kind of scripted within MI. But then tell me why you picked 6 instead of, say, 3 or 4. Giving them a chance again to talk about their sort of readiness to do this. Frames is a brief intervention tool, and if people are familiar with ESPERT screening, brief intervention and referral to treatment in like primary care, looking for alcohol problems, this is relevant to that. The emphasis on personalized feedback, not losing sight of the personal responsibility to change. I think of the kind of cliche, well, how's that working out for you? It sort of brings the responsibility back to the patient or the client. I used to work with a guy, he had a sign on his desk, have a nice day, unless you've made other plans. Putting the responsibility on the individual. Advice or explicit direction to change, if that's sort of fitting. For years in an addiction treatment program, probably 90% of the patients smoke tobacco. At discharge, I would write on a prescription pad, please stop smoking, and sign it and give it to them. just so that they knew where I stood on that. And people would put it on the refrigerator, tell me a year later they finally made a quit attempt, but at least they knew where I stood. Without blaming or shaming, just this is something to keep in mind. Personalized feedback. I've had lots of patients with alcohol issues, almost to the end of the slides, folks. Alcohol issues, they really want to know what the liver function tests show. Because if there's liver damage, that's going to move them toward being more motivated to do something about the drinking. I tell a story on myself. People here believe flossing is good for teeth and gums and stuff. I believe that. For years, I barely did it. And then after cleaning my teeth, the dental hygienist put her hand on her hip and said, "Do you realize you're just one step away from needing to see a periodontist?" I didn't feel shamed. I felt alerted 5 to 7 times a week since. That personalized feedback made a difference. Okay, so here are some things to think about. You're getting this motivational interviewing process that we're talking about. If speaking slowly, patients doing more of the talking, and they're actively talking about behavior change. You're listening very carefully and gently directing the interview at appropriate moments. I did a demo interview on the addiction treatment unit, the co-occurring disorders unit Tyler 1, several years ago. Patient had been in treatment maybe 2 or 3 times, maybe a year apart, not like chain detoxes, I guess you could call it. And before the interview, somebody had told me that the guy was saying, and I was not his attending physician on this admission, I had been in before, and he said something like, well, I was here a year ago, and Dr. Kane gave me his best shot, and I'm back. And that might have gotten like my ego or my self-centeredness into the fray, but it just sort of helped me realize that I better do motivational interviewing and not anything else. So and I just said, the purpose that we're here for is just to learn more about you. And he talked about himself, and I did some reflection and summarizing and affirming, and about halfway or less through the interview, I was aching to talk about 12-step recovery and Alcoholics Anonymous for this guy. I was aching. And I'm thinking, well, do your duty, hold the frame, hold the frame, hold the frame. And I just kept reflecting and affirming and summarizing and nothing else. And in the last couple minutes of the session, he said, well, I've gone to some AA meetings, and maybe I need to start doing that again. He said it. I couldn't have sold it if I had a 300% discount and a bonus, but he said it, and that all the more likely that he would follow through on it. The patient is actively asking for information and advice. One of the toxic things, you don't want to give advice without permission. Earlier this week, a patient I had worked with in like 2006 with buprenorphine treatment, medication-assisted treatment for opioid use disorder, is gone other places, other state, but he was back in treatment at the retreat and asked to talk with me because he's now on methadone and he wanted to know something about getting off methadone and back on buprenorphine. And I told him that I favor a gradual process and get to a low dose and then make the transition, and that could take months. And part of him wanted it right away. But 2 or 3 times after we talked about it, he said, well, I'm going to take your advice. And part of I'm thinking, wait a minute, I'm not supposed to give advice. No, I'm like this MI guy. But I realized that I didn't want to trample on what he had in mind, but he had asked me specifically for that information, and I'd given it to him, and he was thanking me, and I just had to let that alone, and we got through it. We want to talk slowly. I'm not sure I've been doing that. What we can do is take sort of a 5-minute break or 10-minute break. But let's take a 10-minute break. When we'll come back, Darcy and I are going to do a demo interview. And Nayeli, this would be a good time to pass out the handouts on, we have a couple on types of reflections, the kind of guidelines for real play, and then everybody should probably take a couple of these rating sheets so that you'll have the option of doing it in your breakout groups, but also doing it when we're doing the demo interview. Darcy, here we are. When we made arrangements for this conversation, you had said that there was something you wanted to work on, and I'd like to learn about that. You didn't give me much of a lead. You said food. So I'm really curious to see what's up with you and food.
Well, I was been thinking about this since our conversation, of course, and it feels so complicated to me that I thought this was a good opportunity to sort of sort out.
You'd like to straighten things out in your own head.
Yeah, so.
Excuse me, I have to break. Do people have score sheets, and are you making, I want you to score this in terms of whether I make reflections or open-ended questions or whatever. So I've got one open-ended question and one reflection so far, if that gives you a lead. But I'm sorry, Darcy.
That's okay. So I've had some injuries, and I've been rehabbing them, and so I've lost weight, and then had these injuries, and then gained weight, and then lost weight, had more injuries, and then gained weight. This is the devil of having a horse, actually. So, in any case...
Is the weight the horse's complaint or your complaint?
The weight is my complaint. So, and could be the horse's complaint, actually. So that's one of the things, one of the reasons why I'd like to lose some weight is that I would feel more comfortable riding and my balance on the horse would be better.
And going up and down with weight is your concern. Food is connected to that.
Yes, food is definitely connected to it. So the place where I keep getting stuck is in the evening. So I have a reasonable good breakfast and a reasonable good lunch that I make, and some snacks that are always either fruit or veggies, but then I get home after work and like it all falls apart.
You make healthy food choices during the day,
Yes,
not in the evening.
that's correct. So, my intention is to make more healthy food choices, and I've been working with a nutritionist who's been very helpful and has given me good ideas. So the last time I was there, she said, buy a bunch of frozen vegetables. So I bought a bunch of frozen vegetables, and I've had frozen vegetables one night. I did have, and it's been a week since I saw her, and I had a salad, and so her idea is to sort of bulk up with fiber and veggies, and then maybe I won't want to eat crackers with butter, or that seems to be one of the things that I had gotten into, or nacho chips, or with cheese, as much melted cheese on it as I can have, and it just becomes this kind of like, first I have one little thing, then I have another little thing, then I'm having a couple little pieces of chocolate, and then I'm having a bag of microwave popcorn, and I'm way overstuffed, and I'm not stopping.
You're working hard, you're taking suggestions, you're making some changes, and then an avalanche happens.
That's right. And even the night that I ate the veggies, or the night that I had the salad, the same thing happened. So that's the part of me that it's sort of earlier when you were talking about addiction being in this part of the brain, I'm like...
It's hard to know what to do about it.
That's right, because it just feels sort of like a kind of dissociation. But the other thing, and this is where it sort of feels like I'm not sure whether this takes us off the track or whether it's a part of it, is that I have right now, because of sort of things happening in my family, have set up my schedule so that I'm here a little later Mondays and Tuesday mornings, and then I work until the last patient that I see comes in at 6. And then by the time I get home, after I've done some charting and whatnot, checked the phone to make sure there's no urgent voicemails and emails and all of that, it's sometimes as late as 9 o'clock when I get home. And so maybe I've even eaten snacks here and I'm not all that hungry, but I'm a little hungry, and then this like thing happens.
Well, you work late and prevent the avalanche.
No, I work late and the avalanche is almost worse. You know, it's like I'm really tired and I don't want to eat a lot. And so I start with some little thing, like a few crackers and a little cheese. But then it's like another little thing and another little thing and another little thing. And I'm not really ready for bed yet, so I'm staying up late. And then the next day, which is another long day, I'm really tired. And so it feels like knowing that sleep is an important part of losing weight, and knowing that not being tired, because then our brain doesn't make good decisions, and all of that stuff is just like, I just feel like I'm beating my head against the wall, and I just feel so stuck.
Your persistence and diligence at this is admirable.
Well, thank you, but it doesn't seem to be getting me anywhere.
You mentioned the nutritionist suggesting bulk and salads and frozen vegetables. Are there other things that you and the nutritionist have talked about?
Oh, sure. So one of the other reasons that motivated me to see her was that my A1C was not off the charts, but it was just a hair above normal. So my doctor said, okay, now you're in pre-diabetes. And I'm like, I am not going to stay there. And I've dropped it down. So now my doctor's not worried about it. The nutritionist isn't worried about that. But like, I had cut out some things, like because of achy knees and other aches and pains, I'd cut out sugar and still don't really eat. Even though I have chocolate, it's always like really that very dark chocolate that doesn't have very much sugar in it. So I try to keep anything that I eat that has refined sugar in it down to like 5 grams or less, and the nutritionist thinks that's great. And I've been trying to, and have been able to adhere to a gluten-free diet because the rheumatologist thought that was a good plan, along with reducing the sugar. I have worked really hard at this.
Indeed. And you've had some success.
Yes.
The hemoglobin A1C is lower. Your knees aren't complaining as much as they were.
No, my knees
The
are...
horse is not complaining as much as...
Well, no, so that's the other thing, is that what's really interesting is sort of, to me, is that my weight has really not responded. So actually my knees are pretty cranky. And so since I'm not doing the other things, it lets me know that it's the weight. And every time I've gone in to see the primary care doc, it sort of feels like it's been on one of those, she hasn't seen me during the downswing, she's just seen me on the upswing. So as far as she's concerned, my weight is steady. Like, so what's the problem? Your A1C has come down, your weight is steady, you know, you're good.
Your doctor doesn't appreciate the problem that you have with this.
Not really, not really. And unfortunately, she doesn't really have the time to sort of dig into it. So anyway, so that's why I thought we could talk about food.
You mentioned addiction at one point.
Yeah.
And would you be interested in some thoughts that I have related to what we coach in individuals seeking to cope with addiction?
Sure, we can talk about it.
Well, and you may have covered things like this with the nutritionist, but it wasn't clear when I asked about that. When I talk with individuals about addiction, there's a lot of technology we use these days to help people, but I talk about the basics being things are happening and evolving from the primitive part of the brain, which is what you identified with. So that the individual can't trust themselves and can't trust their own judgment. So I teach the phrase, keep your distance. And with addiction, if the addiction is alcohol, that might mean not hanging out with the bottle gang or the sports bar or the country club or wherever the addiction would take place, and don't even have it in the house.
Right.
And a behavioral approach to food issues is to not even have it in the house. So it sounded like you got in the vegetables and you got in the salads, but there's still the cheese and crackers and the nachos and whatever. And if they're there, they're more accessible to you than if they're not there.
Right.
So and you've been disciplined about this a lot. If you're disciplined in the supermarket so that those things aren't there,
Right.
then it might make the avalanche less likely to happen.
Right.
The other thing in addiction treatment is ask for help. Talk about your story and your feelings. You're doing wonderfully with me, and I guess the nutritionist, but your primary care provider doesn't have the time for that. Mm-hmm. So that's some stuff from the point of view of addiction, but does that seem to fit with your situation? Is that useful?
It is useful. I mean, I have thought about, so there are these little matzah, gluten-free matzah crackers that I have found and that I just really, really like. And so I've thought about not getting them because those are the ones that, especially when I get home at night, they're mostly potato starch, right? So they're not really additive food. They're certainly not whole food. They're really refined. And I've thought about not buying them, and I think that it's really interesting to me that has become a treat food, because most people would think, they're really bland and there's nothing to them, but somehow for me, it's like to not have them feels like a deprivation.
You deserve a treat.
Kind of, yeah. And same thing with the nachos. And so on the other hand, I clearly can't handle a treat, and at least not those treats because, I just think about this. One of the other suggestions that I got from the endocrinologist about, who's seen me because of the A1C and other stuff, was worried about my calcium, and she said, get some ricotta cheese that's like low fat, and it's got so much calcium in it. And we were looking at these different things. And so if I have ricotta cheese and raspberries and blueberries, it's like having ice cream, and it's just, if I eat for breakfast, it just is so delicious. And that can be a treat food that feels really healthy. And so it's interesting, though, how this deprivation feeling comes in.
You found you can treat yourself without feeling deprived with ricotta cheese and berries and
that's
and
right.
the like.
That feels like somehow I'm cheating, which is kind of fun.
Okay. You deserve a treat. You deserve exhilaration. That's okay.
That's right.
Yeah.
That's right. And so, and I think actually if I made the time to just heat up the darn vegetables, I would enjoy them too, and and so that's where this other piece of somehow planning my day makes me more vulnerable to not being as adherent or keeping my distance or being as successful as I'd like to be.
You're hard to satisfy when it comes to success.
Maybe. I just want to feel better. Like I don't really care. I've gotten to the point where I don't really care what the number is. Don't care what the number is on the size of my pants, and I don't really care what the number is on the scale. But I do care that my knees are aching and that I feel out of balance when I ride.
Your hemoglobin A1C is down. You found ways to treat yourself without feeling guilty about it. Your weight hasn't been going up.
That's true.
And you'd like things to get a bit better than they are.
Yes. Yes, we're tweaking maybe.
And you have assets going here in terms of your diligence and ability to appreciate some of the scientific things and you're being discriminating about what's sort of a treat and what's a compromise of what your goals are.
Yeah.
And it sounds to me you're well on your way and have difficulty appreciating that.
I do have difficulty appreciating that. I mean, in some ways, there's like, my brain has just been going, yes, but, yes, but, yes, but, yes, but, as you went down that little list. Like, I do appreciate that I have done all those things, and my knees still ache, and I don't feel imbalance on my horse. So it's like, since those are the kind of the two things, like, I don't want to be crippled at my age, and it's sort of like, so that's very highly motivating to me.
And our lead word was food.
Yes.
Your concern is about weight and the consequences of weight.
Yes.
Are there things other than food that you've thought of as relevant?
Well, the not getting good sleep, I think.
Mm-hmm.
The sort of I don't know. I mean, it's sort of, maybe I'm just stuck there. Because it sort of feels like if I don't have these sort of little binges in the evenings, then I'm going to be better. But, the other thing is stress, actually, now that I think about it, right? Like, this is a hard job that I have.
You deserve a treat.
I deserve a treat. But not just that, it's sort of like my brain is pretty exhausted by the time I get home. And so it is really hard to think.
Little binges are a break and enjoyable.
Yeah, right. And not on the one hand, they're enjoyable until the next morning when I go like, or even as I'm walking up the stairs to bed and I'm going, oh my God, why did I eat so much? It's
You've got this inner scolding mechanism.
I do have a really good inner scolder. Mm-hmm. Yeah. And I just noticed that I had this little tiny bit of shame and self-awareness. Like all of a sudden I'm like, why did I sign the video release?
Right now.
Yeah, like, So, yeah, it's very intense for me on some level that I have this kind of out of control behavior. It doesn't go with kind of how I see myself either.
There's a clash there.
Yeah, right. So, I don't feel like this is a life-threatening situation, clearly, right now. Like, whereas when the A1C started going up, that made me pretty worried.
And you dealt with that.
And I did deal with that, and I've been able to maintain it, and I'm going to have it checked again soon. And so I'm not forgetting about that. But I think, I actually really like that you had the sort of suggestion about not having certain things in the house, and that I had been thinking about that. Like, really, if I sort of pull back from the things that I have kind of gone crazy with in the evenings, and limit it to sort of, I think I just need to be a little more planful for what will happen in the evening, right? Like, I'm planful about breakfast and lunch, and that is very and snacks, and that is very helpful.
Clearly.
Right, and so if I could somehow sort of in my mind be like, no matter how late I get home, if I'm hungry, I will eat this, and that'll be plenty. And then not have those other things to be sort of saying, well, but...
You're resetting your expectations in a healthier way.
I'm trying.
Well, and you're expressive. You're an animated person, pleasant to talk with. Your face lights up when you talk about the little binges.
Does it?
I picture you in the supermarket
Yeah,
getting excited about chips
yeah,
and making sure that you have them. And the addiction treatment would call that protecting the supply.
sure.
And what you just told me was being more cautious about the supply can help you.
Right.
I
Like, I
agree.
don't really have to actually walk past the matzo crackers. Right?
Keeping your distance.
That's
right
right.
on. You are listening.
And I have, like, if I don't, it's really crazy, but if I really just decide, you know what, I'm not going to have it, that does work for me. And I have actually significant experience at losing weight, so if I just decide I'm not eating chips and cheese, nachos, then it will be okay. But it is like, I really have to get firm in that.
That's a decision. You'd keep that decision even when they're in the house.
Yeah, right. There's actually a lot of crap in the house because my partner eats like a child. But
So some of this is unavoidable in terms of access to things.
that's right. But it's like, I could have potato chips. I don't. I could have those crappy cheese balls. I don't. There are just, I could have ice cream. I don't. I mean, there's just a lot of these kinds of things that, even though she eats them, I've just decided they're not really, for whatever reason, appealing to me.
You've already developed the muscle of avoiding things that have some appeal.
Yeah.
And you're planning to extend that to include some of these other things
Yes.
that you've,
Right.
in your word, binged on.
Right. And so, so we will continue to have corn chips in the house, and I probably can actually manage to limit them a little bit better. It really is those darn matzo crackers, man, which is crazy.
Well, and
It's so interesting because it really is like the most refined food that I eat.
well, and you get to decide whether you treat yourself in that way or not. And it's clearly a treat. And one option is to stop eating it. The other option, in terms of the distress that you're describing, is to give yourself more permission to,
Eat other things.
yeah. And you said it's not a crisis. It's not. You got the hemoglobin A1C down, and I bet if it went up again, you'd do what it took to get it down again.
That's true.
Maybe it's a matter of coping more with the inner scolder than with food, to be more comfortable with where you're at.
Well, one of the things that I got really interested in was this idea of intuitive eating, and that actually is really about just sort of tuning into whether or not you're hungry, and anything is actually on the table if you want it. Like they're sort of saying there are no forbidden foods. The things that I've limited, like the sugar and the wheat and stuff, is because of what the rheumatologist told me. I went in and said, does this anti-inflammatory diet really work? And she said, yes, it does. I was, darn it. So, but that's been going on for like 2.5 years, and I haven't really missed those things in particular. Although now I've found this little substitute for kind of crackers or whatever, saltines.
You play by the rules.
I do play by the rules. So now this more open rule is a little confusing. And so to sort of, but I don't like scolding myself.
Well, the open rule gives the scolder less to work with.
That's true.
Are you okay with stopping here?
Absolutely.
In terms of feedback, I'm the interviewer. I want to say something about my experience. I'll ask Darcy to say something about hers, and then sort of open the discussion. My experience in this discussion was staying away from my own issues and bags of tortilla chips. and I had expected to keep the discussion with Darcy's material, but we got to a point in the conversation where I wanted to bring in some material about addiction and recovery, and so I was careful how I did that. I sort of asked for permission, did it, and then asked for how she responded to that, and it actually fit with where the discussion went. So I was pleased, a little relieved that went okay.
Yeah.
But Darcy, how was this for you?
Well, I felt heard and enlightened. Like, it was nice to have a mirror. As far as like the comment that you made, like your face lights up, was really, I didn't expect it, and I, of course can't see that. And I think, I do feel like I feel validated that this sort of little change that I've been thinking about making and kind of avoiding is an appropriate one to follow through with now. I feel a little more motivated to do that and at least try avoiding the matzah cracker aisle.
Now, I will also say I wanted to, as best I could, stay in alignment with Darcy and be her fan and appreciator and give her room to do the things that she's going to do and allow her feelings about this to be valid. And I think if this seemed to go well from your point of view, maybe I was able to maintain that. Questions, comments? We all thinking about tortilla chips or not? Yeah.
Yeah, the first comment is that I agree with you, those matzo crackers are delicious. Find them to be a delicious treat. I have two things that were coming up for me as I was listening. One was there was some, I think because I probably really resonated with a lot of the things you were saying. I was really in it. But I was feeling a little bit frustrated that, in a way, that there wasn't more advice. Like, I was feeling like I wanted more direction, or it was a very reflective experience, obviously. And there was some part of me that was wanting, it was like that little kid when you ask for homework help and you want the person to give you the answer, and instead they sent you to the dictionary or whatever to do your research. It was sort of that experience. And the other thing is the process really required that Darcy be fairly self-aware and able to have some capacity to reflect and be thoughtful about her experience. And I wonder how that works with someone who maybe is in a more acute state and maybe experiencing psychosis or something like that, what that might look like.
It's worth saying over and over again, motivational interviewing is at most a piece of what we might do in a clinical situation. And there are lots of other things that are relevant in some clinical situations where it's not so relevant. And in dealing with individuals with addiction or maybe depression who are not as forthcoming. I wasn't sweating how this would go at all, because I knew Darcy would more than hold up her end of it and let me be sort of the MI guy. But when I've had individuals who are not particularly aware of feelings, don't have a vocabulary for talking about that, have difficulty taking, sort of seeing a role for, taking responsibility in the sort of cause and effect that happens in all our lives, I've found myself talking more than I'm comfortable talking. And perhaps I'm out of frame, perhaps I'm responding to what's going on in that relationship, and the things I talk about sometimes model how our humanness works in a way that might give them some example and ability to identify with something that they don't have the foundation to work with.
Thank you.
Dan?
It seemed like there was reflections and affirmations were combined or came in close quarters at times. Is that
Sure.
am I accurate? Yeah.
I'm not surprised. You're the one who's there thinking about it. And I wanted to state the rule, you can only score one thing. So you make a judgment call and put a mark where you think it's most appropriate. Does an example come to mind from the dialogue here?
Not a particular example, but I just remembered times where it felt like you were affirming what she was saying and also reflecting things back. You were reflecting things in an affirming way.
Yeah.
Right?
I'll be interested in sort of my further discussions with MI trainers, how they handle that, because they'll take full interviews and score it and work with it. In practice, I'm most concerned with the relationship and making the connection, and I did a little scoring in my head in the first few minutes, but wasn't into the scoring. I think the double-sided reflection that I gave an example of included a metaphor and included the reflections. And I don't know, just anybody want to talk about the scoring that you did here? What sort of things did you come up with in terms of counts? I threw a few metaphors in there, like the avalanche or whatever, and that would be a reflective statement. Depending upon how much was with it, it could be simple or complex. But
I found there were more affirmations and reflections and less. The lowest tally I had were open-ended questions
Okay.
and summaries. I found I was kind of seeing more reflection and affirmation than summary as well.
Other people similarly? And I, from my point of view, I would agree with that. There were a couple of fairly detailed summaries in there that I thought that you might have had a couple more, I don't know.
Well, I have a question about what your thought process is while you're talking to her. Do you have at what point are you kind of building the map for, I don't know if it's immediately or if it develops over time, where you know kind of where you want to help? Her motivation was fairly clear in this situation, but she had some themes like deprivation and the scolder and cheating and things like that. While you're talking to her, are you kind of orienting to some of those themes or concepts to get a direction, or are you just trying to keep her exploring?
Okay, great question. Great question. The issues began with food and weight. And as we discussed it, the priority in my mind, people come into a doctor's office, they have a chief complaint. The most important thing medically may be very different from what they come in for, because you learn something else. Well, as Darcy started to develop this, in my mind, it isn't an emergency. She dealt with the crucial biologic measurement that might have. So the mission of our conversation for me was to see if I could help her get more comfortable with where she's at, and if it suits her to lose some more weight, go ahead and do that. But where my heart went out to her was that this is such a bloody struggle, and the scolding seemed out of place. So we talked about value neutral ambivalence and dilemmas. I went from my thinking moved more to this being a fairly value neutral thing. Objectively, I don't think it's a big deal whether her weight goes up or down, but I think she deserves to be more comfortable with where she's at and where she's going. And so that's where my focus went.
That makes sense.
I have a question. So I threw out a couple of invitations that you didn't take, like the stress and sort of being tired and things like that. And I wondered whether it was just wanting to keep this very, very focused, or whether you felt like they weren't so important.
I probably wasn't listening.
Oh.
I think it was that was like 2/3 of the way through,
Yeah.
and that the stress would have been a perfect opportunity for an open-ended question, and I think somewhere I resisted that because I was sort of time conscious and thought we would have to wrap things up, but to me, in retrospect, clearly a lost opportunity. And the stress, to me, is probably more of an opportunity than the tiredness, but both are deserving.
I
Yeah.
tallied the stress and the tiredness as sustained talk. I don't know if that was correct, but I thought that's why you moved. I thought you intentionally were not picking those up.
Yay.
Thank you. Yeah, good job. That may well be. I think there's more to who we are and why we do the things we do than what meets our own mind, so I can't be clear about that. But the intuitive stuff plays a role. Is that good? I think we may have time for 2 of the real plays. I thought after the fact that, and I think in the conversation I didn't get to an explicit reframing between us, but in response to one of the questions, I thought more about it, and I was thinking that the issue was more the dynamic between you and the inner scolder than it was actually about food.
Mm-hmm.
And you followed through in that direction and made some peace with it.
Yeah, I mean, I'm sure that just given sort of how I grew up and things like that, my inner scolder is really pretty powerful.
Let's say has been really
well,
pretty powerful.
has been very powerful. I'm trying to allow it to have a little less power.
I think you're succeeding and getting a kick out of it.
Yeah, I am actually.
Yeah.
It does. It felt really good. I was frankly surprised that relatively brief conversation had made such a big difference for me in, this period of time.
Well, and I would say because you were so open to it and forthcoming with what's going on with you, that helped you rethink and reorganize your thinking in a very healthy way.
Yeah.
And that's how this thing works. I sometimes refer to motivational interviewing as clinical magic, because it may not take much if your openness and willingness is there and you're in touch with some values like you clearly are.
Yeah.
Wow.
So I'm still staying engaged with the nutritionist for a while.
Okay.
Because I think that it's helpful for me to have she's not actually a scolder either, but to just have an outside person who's helping me monitor this and not feel like, and that actually also gives me a little more room to quiet down inside.
Yeah.
So that's good too.
Well, this is fascinating and exciting, and let's high five and keep it up.
All right. Thanks.
So I'd like to just briefly check in with any of you that have some comments on what that experience was like, what your role was or roles were, and how you found it.
So as the role of the therapist, at one moment I felt stuck. Like the questions that will come up to my mind,
Yeah.
I was kind of like, I think this question is going to be too directive and not as open. Like I didn't want to guide her. It's like I feel like this question I'm guiding her to what I want to go. So I had that struggle with myself, and Joaquin came to the rescue with another question. But yeah.
Well, and I think on the instructions for real play, there was the possibility of having a lifeline to check with the observer if they had a question. In a separate training, Lisa and I had an interesting discussion about the MI process, I think, and said, isn't this like the Socratic process? And that made me stop and think what little I can remember from that. And we went back and forth in discussion, and I think Socrates would question people to lead them to the conclusion that Socrates had in mind. And motivational interviewing isn't doing that. It's getting to appreciate the dilemma the individual has and getting to some sort of possibly closure and action planning based on their dilemma, their struggle, and their values. So it's not and in a directed interview where you there's a clear healthy, unhealthy, cocaine binge on the weekend or not, there may be more steering involved than when it seems less clear. Anyone else? Reflections, yes?
That actually came up a little bit in our discussion where there's kind of this dialectic of sometimes if there is a clear healthy, unhealthy, that you want it to be, you want the client to be leading, and yet you do on some level have an agenda in mind. I mean, you would prefer that they move toward the healthier option. And so it's just an interesting thing to note and work with.
Yes, and I encourage us all to be sensitive to where we may have a bias that doesn't fit the values and situation of the individual. I get in this all the time. I am not a particular fan of marijuana, which is now legal for recreational use, and it has a medical role. And I have patients all the time who are. And there's a certain informational role that I provide in terms of wanting to make sure that they appreciate there is a downside, and respecting autonomy, and they get to choose and they get to deal with the consequences that may be therapeutic or may be the opposite in their own lives. But I try to get their bias and my bias out on the table so that we can have a discussion. And I may try to get them to contemplate a little bit why it might not be good for them, but that's as far as I can go.
I mean, I really think you could focus motivational interview trainings toward that topic in particular, because I see it all the time, and I have it as well, where there's this opposing force across the table or between the therapist and the client. And I think in Vermont we're in one of the highest use, or the highest use state for that substance, right? And it's in this new window. And I think it's a perfect opportunity for a technique like motivational interviewing, because if you enter into that power struggle, it really doesn't go anywhere.
Don't.
But you want to be able to you do want the person to be able to acknowledge the downside, because a lot of I don't want to say it's easy to glorify, but it happens so readily.
Well, I think we or you or I may really want to get them to acknowledge the downside, but that's sort of taking on the role of persuasion. And we may want to get into whether they have a value on memory and punctuality and respiratory health and things like that, which it may be opposed to. But our objective is to understand the individual and help them sort out what is in their best interest as they perceive it. And we may have a bias about that. I'd rather that you live to be a grandparent and get whatever that is as far as satisfaction in your life. But if I'm living fast and furious, and that's my accepted fate, people can be pretty fatalistic about stuff, then a reflective statement, you're not really invested in living to old age.
Yeah, it'd be much more powerful.
Just get it out there. Any other reactions, thoughts, reflections on your experience? Yeah.
Mike had a question.
Sure.
Which was, I think Gordon says that one of the things that is a block is praise. How is praise different than affirmation, or the other way around? Affirmation different than praise?
I would feel this as the affirmation being more specific. In our interview, you really responded to the biological measurement. You're thoughtful and diligent, and I think those were all affirmations. And praise, flattery. Oh, you're such a conscientious person. And letting it go at that without making it specific and something the person can feel and absorb. Have any of you ever said to someone, "Oh, you get me"? How does that feel if you say it?
As a person receiving that, or
I want both sides, so give me both sides. Is the person saying it the person receiving it?
I think it depends on the person that says. I've had someone say it to me in a situation where I was like, really? Like, I feel like I don't at all. But then I've also had someone say it, and it feels it's like, oh, like that's great that we're at a mutual respect kind of thing. So
Okay.
I think it kind of depends on the situational.
It's okay, I like that. Anybody else?
I feel similarly, like if to say that to someone, I feel like it feels better than to have it said to you. To have someone say it to you can be confusing, or like, oh, okay, oh, we're going there, right? But to say it, I feel like it's more rewarding to say it, like, oh, you get me, like, yeah, I'm directing you, like, you get me. You know?
Yeah.
Well, and I'm thinking of a situation, somebody I'd worked with for a while, and I said something, it may have been sort of a compliment of praise or an affirmation, but I said, even working tough things with you is like play. And the person who is lighthearted about how they work said, oh, you get me. And I think she felt something and I felt something, and that was a nice moment. And I think what we're looking for in the relationship that we're in when we're doing motivational interviewing is to have get me moments. A couple times Darcy really laughed heartily, and I think she felt recognized and understood, and she was kind of amused by herself, which was, and those are the kind of moments that I think move people forward. Any other sort of comments from the breakout experience? Some of you weren't in the room when I showed my last slide, but it's a lifeguard on a beach, a shark in the water yelling help, and it's called the lifeguard's dilemma. And my encouragement to all of you is serve others, help others, but don't be consumed by your work.